As an occupational therapist, I look at a patient's ability to take care of themselves. So pretty much in the hospital, it starts with the basics: toileting, grooming, bathing, dressing, all the things they do on an everyday basis. So typically they're up and moving and out of bed doing all those things. So with nursing, it's important to talk about how the patient is doing medically before we go and see a patient. That way we make sure they're appropriate. Also talking with nursing and seeing if the patient has been out of bed or if they've been helping turn or helping bathing themselves, toileting, all that thing, just to make the process smoother when we go and evaluate the patient. We really aim to help nurses in talking with them after our evaluation, and that way we can relay their mobility, how they're able to get up and turn. That way they could use a bedside commode if they can, or walk to the toilet, really minimizing using bedpans when it's not necessary. Also, we could really help reducing the risk of pressure ulcers, things like that, if they're able to get up and move fairly easily, encouraging nursing to do that without therapy there. Positioning them in a way that they're more functional, even in bed, able to help with feeding themselves. I see a lot of times nurses just automatically like put the pills in their mouth and like help them with the drinks and stuff. Getting the patients to do as much as they can for themselves while they're here in the hospital. That way they get more independent faster. And that's our goal in therapy, and I know nursing can help out in that sense too. As occupational therapists, we see any patients that are weaker. It could be just overall endurance. That way it's affecting their ability to complete their ADLs independently like before. We also see patients with any upper extremity weakness, positioning, sometimes injuries of upper extremities, anything like that. Sometimes PTs get order on like a finger that has been amputated or injured, anything like that, and usually that's something that OTs address specifically, and we make positioning devices as well. So any patient that you see that might not be able to do their daily tasks like they were doing before, or upper extremity weakness, or even just overall endurance, those are the kinds of patients that we see and evaluate. And of course, if we don't have orders on, as nurses, being able to advocate for the patient and talking with the team and asking for orders if it's appropriate. Like I said, communicating with nursing about if they've been out of bed, if they have attempted to move a patient, things like that is one of the biggest things that help us do our job. It would be really helpful if nurses could disconnect patients from anything that is not crucial to run at that time, even like feeding tubes, extra lines, PrimaFits, things like that are just one step that will help us be able to get a better idea of how the patient's doing. Also, a lot of people wait till therapy comes to see a patient to get them out of bed, but we really encourage all staff to try and mobilize the patient as soon as they can. So starting getting the patient edge of bed, and even if you feel unsafe, then returning them back to bed, but at least attempting, because a lot of people just hold off and think therapy are the only people that are able to get them up. So it's really important to work as a team, getting everybody moving these patients as much as they can while they're here. That will reduce the length of stay, and also, like I said, pressure ulcers, a huge thing, and that way hopefully patients could go home instead of having to go to a facility if they're getting weaker just laying there in bed. Also, we a lot of times as occupational therapists make splints for patients, and we sometimes require the nurses to put them back on. So if you're not comfortable with knowing how to put a splint on or anything like that, just reaching out to the occupational therapist on the floor, and we're more than willing to show you guys and educate you on the use of the splints that we make and we order as well. We rather you put the splints on correctly than put it incorrect where it could cause a breakdown or even rubbing. So it's better just to reach out, and we're more than willing. And that way we can work as a team to position the patient better, get them moving faster, get them helping with all their daily activities while they're even here in the hospital. A common misunderstanding with our role as occupational therapists is that we don't get patients out of bed. So one of the biggest things is when you're completing your daily occupations is you're out of bed and moving. And so that's why we work hand in hand with physical therapy, getting those patients moving quickly. And that way they're able to become more independent. So that's something that a lot of people are like, well, you can just do in bed assessment, things like that. But our goal is to make the patient as independent as they were before. And that's usually getting them up and moving and walking them to the bathroom and in the hallways or whatever it takes to get them back to their level of independence.